seminars which are called the Patient Safety 101 series. So these are designed to introduce people to patient safety concepts and theories that they might have heard about, but don't necessarily feel like they know a lot about, and also for people who want a refresher, or people who are just genuinely interested in hearing experts talk about an interesting patient safety subject. And we do have two experts with us today. So we're delighted to welcome Dr. Ruth Baxter. So Ruth has been a member of the Quality and Safety Research Group for many years, and she's also based at the University of Leeds. She holds a postdoctoral fellowship from this institute based in Cambridge, and she's looking at health service research at the moment, and she's looking at how resilient healthcare theory can be translated into practice. So very much looking forward to hearing her views on and her experience and knowledge about resilient healthcare, and how it is a growing, those theories are growing within the patient safety community. And then we also have Brook Howells. So Brook, we're really lucky to have Brook at the PSRC as a PhD student, because she is actually a human factors specialist with many years of experience, including in the NHS, supporting quality and safety improvements. Her PhD with us is exploring how safety management systems can function in high hazard industries, and looking at that with a view to how it can potentially benefit healthcare. She's very much interested and experienced in asset-based approaches to safety, and that very much chimes and aligns with the resilient healthcare theory. So I'm going to hand over. I think I'm handing over to Ruth first, or I'm handing over to both of you.
Me to begin with. Thank you so much, Brooke. Brooke.
It's difficult with these B names.
Yeah, thank you very much, and to the PSRCs for inviting us to give this. I don't know what we call it, a training session or whatever it is. So basically, this session is kind of aims to provide an introductory overview of what resilient healthcare is, and it's often also known as Safety 2. That might have been the term that people are more familiar with potentially. And give you just an introduction to how that fits within other asset-based approaches that are used within the NHS at the moment. So you won't have to listen to me and Brooke drone on for the whole hour and a half. We're going to try and mix it up with a bit of presentation, a bit of kind of discussion and interaction, and a couple of activities. But also just to say this, we know that there are lots and lots of expertise within the group as well. So please do chip in, put your hand up, add your own perspectives, use the chat, etc. There's no stupid questions or comments, and we're just really keen to get your thoughts on this as well. So yeah, welcome to everybody. We're looking forward to the next hour and a half. Is there anything you wanted to add, Brooke? Yep. Fab. So we thought we'd start, well, let me share my slides to begin with, which might help. Can you see that?
On its way. There we go.
Yep. Yeah.
No, fab.
Brilliant. Yeah.
So we thought we'd start off just by really trying to understand from the group what you already know and what questions you have about resilient healthcare, Safety 2 or other asset-based approaches. So appreciate that this is a very hard start and you've cold shoving you into conversation and discussion, but please feel free to, I might actually stop sharing for a second actually. Sorry, this is a bit silly. Just to let people just kick off and say what you already know, what you want to know, and get out of this session. Feel free to use the chat if that's easier. We'll hopefully plan to address that, or we'll try and address it if we've not. If people have just come for an interesting listen, then that's absolutely fine too. Go on, Jess.
Hi. I must admit, I don't think I know much about it, but when I read the little blurb about what this was about, I was really intrigued, and I'm quite interested in learning about what's going well in systems. So is it more about that rather than always looking for what the problems are?
That's an element of it, yeah.
That's good. I'm excited
Oh.
then. So yeah, I'm in the right place.
Great. Okay, fab. Well, we'll kick off then, and I'll share my slides again. So what we're going to do over the next hour and a half is initially just give you a bit of a critique about how we currently try and manage safety within healthcare organisations, just to explain kind of the background as to where this approach is coming from. Then we're going to explain this kind of different perspective or different way of thinking about safety called resilient healthcare. We'll talk about how that fits in with NHS policy and other asset-based approaches that exist and are being used within organisations at the moment. And then we'll have a think about how this applies to us as researchers in the work that we're doing within the PSRCs. So I think broadly we're coming at this from we're talking about this is what healthcare organisations do to try and improve safety. So like an improvement perspective rather than a research perspective. But we're going to try and flip it and think about how we might apply some of these concepts to our research towards the end of the session. So this many of you may or may not have been to one of the earlier Safety 101 sessions held by Jerry Armitage, where he kind of gave a history of patient safety. And this session, he's kind of started to touch on resilient healthcare and safety too, as a kind of newer perspective that's been talked about a bit more. And this session is kind of trying to take that bit forward and explain that a little bit more. So, how do we currently try and manage safety within healthcare? So, the predominant focus within organisations, traditionally, we try and improve safety by basically focusing on trying to reduce error and harm. So these are lots of different examples of patient safety issues that many of us will be aware of and be trying to improve as part of our research as well. And we have various different methods to try and reduce error and harm, but the kind of overall premise of what we do, and then this is being very simplistic, but broadly what we try and do is identify something that's gone wrong. We try and understand why it's gone wrong, and then we try and prevent it from happening again, or at least reduce the frequency with which that might happen again. And this is based on a bit of an assumption that if we do the right thing, we will. Is somebody unmuted? I'm just going to hear myself a second. So it's based on an assumption that if we do the right thing, then we will get a successful outcome or care will be safe. And the opposite to that is that if we do the wrong thing, something bad will happen or the care is unsafe. And so we try and the focus in trying to improve things is that we try and focus on reducing the number of things that go wrong. So we try and reduce the wrong things that happen. And our solutions tend to include things like checklists, putting checklists in place. We train staff to do the correct thing. We write a policy or a guideline that tells people how to do the correct thing. And to a small degree, research can be similar. There are many differences, so we often have far more resources to try and understand and unpick some of the underpinning factors about why things go wrong. We use obviously lots of theoretical lenses to try and understand those problems. Also, our interventions are far more complex than simply adding a checklist in or training. They've often got multiple components. But we broadly try and understand, we try and kind of deliver an intervention, and then as part of that intervention, check if people are doing the intervention in the way that we intended them to do it, whether they're doing it correctly, as a way of trying to understand whether our outcomes do or don't, our intervention is or isn't successful. So this is what we try and, we try and reduce things that go wrong with the assumption that will stop bad things from happening. And this approach has led to lots of improvements within safety. So, for example, we've got the WHO checklist, medicine bottles, etc. But there are lots of stubborn and complex problems that do remain within our healthcare system. And these problems are enduring. They have existed for many, many years, and they aren't really improving things like hand hygiene, infections, etc. So there are various different perspectives on why some of these complex problems remain retained within our system. One of the thoughts is that actually our approach kind of our underpinning approach to how we try and improve safety, essentially, if we really can think back, looks back to the Industrial Revolution and Taylorism. So Taylorism is based on 4 key principles. So it's about trying to understand and determine the one best way to do a job. So if you do it the correct way, then you'll get the correct outcome, the thing that you want to happen. It's about trying to assign people with specific tasks, so that not letting people stray beyond those tasks. It's about trying to monitor work and provide instruction when people aren't doing things in the correct way, in the way that we intended them to. And it's about trying to separate managers from workers. So managers plan and train what people should do and how they do it, and the workers then implement what they are trained to do. And we see all of this in many different ways, through the policies and guidelines that are created within healthcare organisations, through the way we audit and assess and assure things with safety issues within organisations. And this book on the right-hand side of the slide, Still Not Safe by Rob Weirs and Kathleen Sutcliffe, is a really great kind of easy introduction into this kind of history of patient safety. And I definitely, it's really interesting and easy read. I definitely recommend reading it if you're at all interested in patient safety, more broadly as well. So this kind of underpinning approach or kind of perspective is just one way of thinking about safety, and it's often not realised that is just a perspective on how we might improve safety. There are other alternative perspectives that can exist. So there are a series of observations that I'm going to talk you through over the next couple of minutes that basically kind of outline why this perspective might not always be appropriate or might not currently fit some of the modern healthcare organisations that we work in and that people are trying to fix some of these problems within. So the first observation is that healthcare is really, really complex. So healthcare is a complex adaptive system. It's made up of lots and lots of different parts. And those parts act both independently, so on their own, but they also are interdependent on other parts of the system, and they interact with the wider parts of that system. So this, you don't need to see the detail within this, but this is this kind of diagram is a kind of example of a hospital system. And what you can see is that actually, if you take this little bit here as being a ward, it acts independently on its own, but then it's also dependent on things that happen much more widely in the system. That interdependence within a system means that when one thing happens within somewhere within a system, it can have effects on much broader and wider parts of the system that we don't necessarily understand or predict or are able to predict, and those effects can resonate. They can get bigger or amplify in sometimes quite unanticipated way. So one kind of relatively simple, I suppose, like I'm simplifying it a little bit, but way of trying to explain this is if we think about a hospital ward. So the hospital ward operates independently on its own. But say, for example, one morning you've got the pharmacy department, you've got a member of staff phoning sick, or a kind of technical glitch with some of the equipment within that department. That can mean that there are problems within the department, that it means that the medicines aren't dispensed in a timely way. That in and of itself is a relatively small problem, but it can have real effects and really large effects on the wider aspects of the system. So it can mean that medicines aren't dispensed as quickly. It means that then people don't go home as quickly as they originally were intended to go home. That means that then people further down in the hospital at the A&E get held up in A&E, and the A&E backs up, and ambulances then can't get back out into the community and respond to 999 calls as they're coming in. So you can see how small things can resonate and have big effects on the system because of that resonance and the complexity and the interdependence within that system. The second observation, again leaning into this complexity thing, is that actually the system isn't linear. So we like to think of our system in this way, where we have activity that leads to an outcome, but actually that's not always the way it happens. So if something goes wrong in this activity, we think, okay, well, we'll just fix that. but it's not possible necessarily always to break down the system into its individual parts and identify a faulty component and then just fix that. The system actually is far more than just the sum of its individual parts. We also assume, as I've kind of alluded to earlier, that if we do the right thing, we'll get a good outcome. If we do the wrong thing, we'll get a bad outcome. But actually, it's our everyday working and our everyday performance where outcomes actually emerge. So if you think about, or if people have got clinical experience, if you think about things, people do similar things day in, day out. And most of the time those things go right and you get the outcome that you expected. But only on occasion, even though you're doing very similar things, does it go wrong. And so good outcomes and bad outcomes are thought to emerge in the same way as a combination of everything else that happens in that system. It's not necessarily possible to identify that faulty component. And actually, it's the ability for people to flex and adapt that often means that the successful outcome occurs. So we work in very, very variable conditions. No condition within healthcare is ever exactly the same. So our patients vary. The clinical presentation of their condition will vary. The teams that we work with constantly vary, and the conditions on the ward will vary. So you're constantly having to adapt to different equipment or equipment not being there, etc. So you're always having to flex and adapt. And so it's this ability to flex and adapt that means that often means that we create safe care, and rather than safe care being there and us doing the wrong thing and eroding that safety. So I think one thing that is important to say here is that we're not necessarily advocating for staff doing whatever they feel like and flexing, adapting all the time to everything. But we need to acknowledge that actually reasonable levels of variability within our system are considered essential to everyday functioning. And that isn't necessarily how we think about variability when we're trying to do improvement within our systems. We tend to think of variability as being a very bad thing, that we try and reduce variability. We try and standardise it or take the variability out of our systems. So, resilient healthcare offers a different perspective that tries to take some of these considerations and assumptions into account. So resilient healthcare as a definition, there's a couple of different definitions, but this is the one I personally prefer because it's slightly less of a mouthful, although it's still a bit of a mouthful. But resilient healthcare is considered to be the capacity to adapt to challenges and changes at different system levels in order to manage high quality care. I'm going to delve into that a little bit more in a second, but I thought it's also just worth at this point to because might well be a number of us within this audience that have maybe a psychology background, to say that what we're talking about when we talk about resilient healthcare and using this as a way of improving safety within organisations is it's very much a systems approach to improvement. It's not about personal resilience. So particularly kind of since COVID, there's been a lot of emphasis on individual resilience, and healthcare staff are rightly quite peeved off about being asked to be more and more resilient and having interventions and mechanisms thrown at them like wellness events and things like that may well be benefit, but do not fix the system issues that they are having to contend with day in, day out. So resilient healthcare is about trying to strengthen the system rather than to make individual people more resilient. I just think it's really important to stress that because this is not about trying to make sure that people compensate for really poor systems. It's about trying to build systems that work for people working within them. So what supports resilient performance? There are a couple of different perspectives and things in the literature, but one of the most kind of well-used one is this these four potentials that are defined by Eric Hollnagel. So he talks about resilient performance being built up of these 4 different potentials. So the ability to anticipate, basically to know what to expect within the work that you're doing. The ability to monitor, so knowing what to look for. The ability to respond, which is knowing what to do when something happens, the ability to respond to unexpected or changing circumstances. And then the ability to learn, so to look back and to understand what's happened and to do things differently on the back of that. And those 4 principles all they again don't stand individually on their own, they all interact. So for example, being able to anticipate will affect what you monitor, and it will affect how you respond. Learning will affect how you anticipate and monitor in going forward. So these are all interacting potentials that basically provide people and organisations systems with the capacity to adapt and to change within the circumstances that they face when working in these really complex systems. So resilience as well, I think it's worth mentioning at this point, is that it's not necessarily a good or a bad thing. Resilience in and of itself is just a neutral concept. It can be both of those. It can be both good or bad. So from a positive perspective, it can help us adapt to kind of changes and disturbances, as the definitions that suggest. So it can help us. We were very resilient in some ways with COVID. We quickly adapted and changed to a major disturbance to our healthcare system. And even on day-to-day issues, we can be very resilient, responding to equipment breaking down and not be available, or patient complications that we hadn't anticipated. Healthcare teams are very resilient to those situations, and that can be a really good thing. But equally, resilience can create issues. So on one perspective, actually, our healthcare systems are extremely resilient because they won't change. They are very resilient to any change that we try and implement it with our interventions and the research that we do. And also resilience can kind of manifest and express itself in different ways at different levels of the system. So if you think of individuals being resilient on the front line, that can mean that the system appears in some ways to be more resilient, seems to be functioning and working really well, but that is simply because individuals are buffering a lot of the problems. They're flexing and adapting to a lot of the problems that they're constantly having to address. But that means that a much broader system level within the team or the wider organisation, it actually masks problems that exist and means that the system itself isn't particularly resilient. So you can look at resilience at different system levels as well and try and understand how it may support or hinder performance within those different levels. So what does this all mean in terms of how we actually manage and improve safety within healthcare organisations? Well, because we work within these complex adaptive systems, this perspective of trying to improve it is predominantly all about trying to understand the problem in a much more deep way. And we are trying to understand that problem not solely by looking at the individual incidents and things that have gone wrong, but by trying to understand that everyday work, trying to understand the complexity of what people have to deal with day in, day out within their kind of environments, within the systems that they work in, and trying to understand how care usually goes, whether that be usually goes well or usually goes wrong. It's just about trying to understand the everyday work that people do in order to understand how that system works. Once you've tried to understand that, it's about trying to think about how do you want to deal with that variability that exists. So we might want to constrain that variability in the way that we traditionally or typically do try and do. It might be that actually that variability doesn't need to exist and there is one right way of doing something, or one way that's the most safe way to do something. And so we do want to constrain that variability. But it might be actually that the variability that we're seeing actually is what's enabling people to flex and adapt and to create safe care. And so actually we might want to leverage that variability that exists within the system and support you people to use it in constructive and safe ways. We might be able to use this perspective to think about how we support the 4 potentials, the ability to anticipate, monitor, respond and learn. So how can we anticipate things that go wrong? What do we expect might happen within this particular circumstance? How might we monitor it more effectively, etc.? And think about how we support those potentials. One of the things that this perspective also means for improvement within healthcare organisations is trying to think about the boundaries that we draw around the problems that we face. So we talked a lot about the interdependencies and interactions that happen within systems, and this is really, really important when we look at improvement. So again, this is a bit broad brush, but typically we tend to draw relatively narrow boundaries around the problems that we want to address. So it's a relatively small problem within an isolated ward, and we don't look at things much more broadly. Whereas actually we need to think about, well, who else within the system interacts and contributes to the way in which we do this everyday work within our particular ward. Who else might be affected by us implementing this solution? So we need to draw much broader boundaries and think about those interdependencies and connections when we're trying to make improvements and understand the problems that we're facing. This does also mean that if we're trying to understand the everyday work, that our problems are very context specific. We need to understand how they exist and manifest within the context specific situations that we're in. And so although there might be things that we can generalise across other healthcare organisations to other teams and departments, etc., we do need to understand the specifics about how that exists within our own team and what the actual nuances and implications are for our teams that we're working with. And the other thing is that the solutions that we create as a result of all of this understanding of the systems that we work in, those solutions are always going to be temporary. What we tend to do at the moment within healthcare is we tend to design a solution, implement it, and then assume that after a period of kind of monitoring and seeing whether it works or not, assume that is it's fixed the problem and that's the problem gone away. But actually, our systems are not static because of this complex adaptive nature of them. They never stand still. And so we do need to constantly kind of revisit some of the solutions that we put in place to see whether they still work and still are working in systems that are constantly evolving. So going back to this point from at the beginning, this broadly is very much about trying to strengthen the system so that it's easier to deliver safe care within the organisations that we work in. So what do we currently know and not necessarily know about resilient healthcare? Well, as I mentioned, there's a lot of kind of underpinnings theoretical work that talks about what resilient performance might be, so the four potentials and some other definitions, and there are lots of, I'd say, pretty descriptions of what resilience looks like within healthcare organisations, so how healthcare systems and teams have adapted to unforeseen circumstances, either the natural disasters like COVID or the just descriptions of everyday work and how people flex and adapt to the work environment that they're in order to deliver safe care. There is, although it's increasing and this problem is kind of reducing slightly, we're getting more and more evidence, but there's a lot less really on how we try and actually translate some of these concepts and ideas into practice, and how frontline healthcare improvement teams and patient safety teams, etc., can use it to improve safety, and whether it actually works and does mean that we through doing this approach we deliver safe care. There's a lot of anecdotal evidence, but not the evidence that our healthcare organisations value in terms of quantitative RCTs, mainly because actually this type of approach is very difficult to summarise and test within our kind of traditional ways of trying to monitor and evaluate interventions. So mentioned that there's another term as well, safety 2, which might be one of the terms that people may be more familiar with. So there's quite a lot of confusion, I think, out there about what resilient healthcare is versus what safety 2 is. And this is the graph that maybe people might be familiar with if you've heard of the term safety 2. And it's the one that's kind of often used as a way of introducing what safety 2 is. So this basically, I would say, and there are different perspectives on this, but I would say that safety 2 and safety 1, that language, that terminology, is basically really a kind of communication tool. It's a way of trying to highlight that there is an alternative perspective that we could take in trying to manage safety within healthcare organisations. And it's something really of trying to stand safety 2 apart from what we've traditionally tried to do. So this graph illustrates that our traditional and typical focus is on this safety 1, which has been termed retrospectively safety 1, on the errors and adverse events that happen, whereas safety 2 tries to encompass all of the performance outcomes that exist and tries to focus on this everyday work. But I think this has been really badly translated into actual practice. Often it's translated as that we should only look at what goes well. We need to ignore all of the things that have gone wrong and just look at how things go right and the positive outcomes that exist within the system. It's not necessarily always understood as being just trying to understand the complexity of the system, the everyday work, and how our systems function. And that almost we're basically kind of agnostic to outcomes in trying to take this approach. So this translation piece, I think, is actually really, really important if we try and think about safety 1 and safety 2 and that terminology that's kind of created this bit of divide around what we traditionally do and what we currently do nowadays. So in healthcare, we have a really great propensity to try and simplify theoretical concepts and theories into much more simple things that we can try and use in healthcare organisations. And resilient healthcare and the safety 1 concept, safety 2 concept isn't unique in doing that. So this is James Reason's the Swiss cheese model that many of you will be familiar with, and it's born from his organisational accident model, but it is often in healthcare organisations literally that theoretical model is simplified down into the Swiss cheese. But actually, his theory talks a lot more about all of the complexity and interdependence and the importance of understanding how a system works, which is a lot of what is underpins safety 2 and resilient healthcare. So it's this translation of how things translate into practice that is often actually a problem. We are increasingly trying to move away from root cause analysis as a method of trying to understand individual incidents that have happened within organisations. We talk about root cause analysis being a relatively simplistic way of trying to understand why an accident happened, but often that is actually done. We kind of presume it to be a problematic thing because it's just done really badly. It's badly resourced with very limited system learning and with a often blame as an individual outcome, a blame of individuals as an outcome of the system. And so this translation problem is rife in all of the theories and the perspectives that we take. Safety 1, as a result of how we've talked about, is often now criticised as being a bit of a straw man, as in something that doesn't really exist. Because the people will say that often if we resourced the safety 1 things that we do much better, if we did it better, then actually we would produce much better outcomes. In many ways, I completely agree with that. I don't find the safety 1, safety 2 terminology very helpful. I prefer to think of the kind of principles that underpin resilient healthcare as being something that can guide the way we do improvement within certain circumstances. I find that much more helpful. But just to try and place the different language within for everybody to understand. These 2 papers are one by Russell Mannion and another by Rebecca Lawton, are great examples of kind of this debate of the safety 1, safety 2 straw man debate, which might be interesting for you to read if you want to find out a bit more about that. So I'm just going to summarise with a bit of a four kind of, I think it's 4 slides of what safety 2 and resilient healthcare is and maybe what it isn't based on some of the understanding. So it is about trying to understand everyday work. It's not just about trying to look at what goes right. So it encompasses the whole performance spectrum and tries to see outcomes as something that emerge from the system. Again, Steve Shorrock's got a really good piece on this. It's resilient healthcare is an alternative perspective to help us try and address some of the real complex problems that exist within our system. It's not necessarily a new or a better or a replacement way of what we currently think. The two things can exist side by side. It's a perspective rather than an approach or a methodology. So it's the application of concepts and principles rather than a process that you follow in trying to do resilient healthcare, as it were. And that's the end. I thought there was another one, but there's not. I'm going to pause there and stop sharing so that we can all take a bit of stock, share some comments, ask questions. I think I saw a hand up a second ago, but please.
Yeah, sorry, that was me. I was just saying that there were questions on the chat, and I don't know if you wanted someone else to read them out whilst you were presenting.
Yeah, we can have a look at those now. Thank you.
No worries.
So Toyosi, as care homes shift away from hospital to the community from virtual wards in HAH services, where I don't know what that stands
That's
for.
hospital at home, Ruth.
Hospital at home. Sorry,
yeah.
Where care is distributed across home, technology carers and clinicians, how did you distinguish between true system resilience and safety maintained by individual workarounds? That's a really, really important question too, and I think it can be quite a difficult thing to distinguish. I think one of the things is about trying to really get into the front line and trying to understand what it is that staff are having to do and the problems that they're facing day to day in delivering that care. So you will see if you go in and observe staff doing the care that they're delivering, you will see the workarounds that they are having to do to compensate for the problems that that exist within the system. So whether they be technological problems and they're having to adapt the system that they use, so going between lots of different systems in order to do one piece of work, having to write things on paper in order to put it into the system properly. You'll be able to see all of those workarounds that exist, and then and how individuals are having to compensate for a lack of system resilience. And that's then when you can think about, well, how can we adapt this system and change the system in order to make it easier for them to do that work so that we're less reliant on individual resilience and we can give them more, we can take away some of the things that they're having to do to compensate and give them back a bit more slack or capacity to adapt to the things where that adaptation is really needed, because it's needed to adapt to things where actually a computer system couldn't mimic that itself, if that makes sense. Have I answered that question? Brooke, do you want to contribute anything else? Do you want to add anything to that?
I was just going to add that healthcare's got a particular challenge that every person we're looking after is an individual, and so there's always going to be some variation that we need to be able to adapt to each individual in front of us that we're looking after. And the challenge we have is being able to identify where the variation is because of the person in front of us, and being able to be inclusive and adaptive for each individual patient, and where the variation is actually it's because there's a process behind what we're doing that isn't working. And it is, I think, one of the biggest challenges of how we separate those two things out, to standardize processes to make them, as Ruth was saying, there's less adaptation needed to work around processes that don't work, that still enable us to be inclusive and adaptive for every person that we're working with.
And obviously in that particular circumstance, Tosi, where you're working in a like hospital to home in a virtual environment, it's more difficult to unpick those things than, for example, in a hospital with all the people there, where you can see how, I don't know, the pharmacist coming out, you can see those things a lot more than you can when care is a lot more distributed. Yeah. Joanna.
Can I say something?
Oh, yeah, go on.
Thank you. That's quite interesting because I've only just started collecting data, and and I'm beginning to see this or think through it. And there's also something that, as healthcare professionals working in a system like this, we are numb to these things, so they don't see it anymore. So it's not a problem, right? And then when I'm trying to talk and say, "But we've been doing this all the while. We haven't killed anybody," so it's now trying for me. It's very difficult trying to separate, these things. Where is this systemic or is this individual? But thank you. So I'll go away and start thinking about how to see, look at these things during my observations, because I haven't studied that yet. But during the interviews, and this was coming up, I mean, we just see like we get through it, we find a way around it, and they're not escalating these things because they don't see it as a problem.
Yeah, and that happened, and don't necessarily see it as a problem or the wider impact it could have. So some of the work, just having a blood pressure monitor, not in the room in a maternity setting within the room, having to go and find one takes a lot of time. It means you're taking one out of a different room, which then could create a problem further downstream when there's an emergency in the room you've just taken it from, and it isn't available. Yeah. These things often don't. So people just work around them all the time, and they're blind to it, really. Yeah. Joanna, did you have a question? Joanna, you there?
We can't
No,
hear you.
no.
You want to put it in the chat?
There's another question in the chat, Ruth, from Hubert, who's asking, thank you for a very clear and interesting presentation. Can you please elaborate on the difference between safety 2 and resilient healthcare? What do we really mean by resilient healthcare? And is improving quality of care part of it?
Yeah. So it's difficult. Safety 2, I would, in a way, this isn't probably the official line, but I would just ignore safety 2. I find it a really unhelpful term that is actually quite polarizing. But basically, safety 2 is just a way of trying to get people to think in a slightly different way, to think beyond just looking at error and harm, and trying to improve it, trying to understand why those happened and improve from that. Resilient healthcare is a I'd say more a kind of combination of concepts and principles that you can apply to trying to understand the system that we work within. And with that understanding, we can try and generate solutions that might be more effective and more useful in the and
Thank
related
you.
to complex.
I wonder whether you can tell.
Oh,
Yes. Can you hear me?
Yeah. Sorry. Yeah.
Who,
Who is that?
No.
who's talking now?
that's Joanna. I think there's a delay on Joanna's audio.
Ruth, why don't you carry on answering the question, and then we can ask Joanna to put something in the chat.
So yeah, it's more a way of understanding the system, so that then you can hopefully generate solutions that are more useful and sit within a complex adaptive system more effectively than what we currently do, which is relatively linear or simple solutions to problems. And yeah, it's not just about safety, it's about you can use the resilient healthcare as a way of trying to improve quality as a whole. So you would always be having to think about how efficiency things impact your ability to do that to do that as well. So efficiency, effectiveness, etc. All of the dimensions of quality. Joanna, is your...
So Joanna's put something in the chat now, which is, how can we operationalise safety 1 and safety 2? As personally, I view them as overarching frameworks in patient safety research. When trying to actually analyse healthcare processes, we tend to use models like SEEPS or Reason's Swiss cheese model. Do you think using models like this makes it feasible to operationalise safety 1/2 concepts in healthcare? Wow, these questions are amazing.
So
I think we might answer that, Ruth, in the next. We've got some more slides to share with you, and I'm wondering if that it might answer that question. And if not, we can come back to it when we've got more time for discussion at the end as well. Because I'm going to talk a bit about what we're already doing in practice and what we might want to do more of.
Yeah. Just thinking of time as well. Yeah. Jacob, do you want to go in with your...
Hi, yeah. Can you hear me all right?
Can do, yeah.
Okay, I was going to ask about operationalizing safety too as well, so I'll wait until after if I've still got questions.
Okay. Well, this is great, guys. Thank you so much. Keep the questions coming, and if we've not addressed some of them, we'll get back to them. I'm going to hand over to Brook now.
Okay, and hopefully this will start to answer the question of how we operationalize it. But as I say, if not, we can continue discussing it. Right. So if I share this screen, hopefully. Is that shared okay?
Yeah.
Perfect. Okay, so I'm going to talk a bit about how resilient healthcare fits with current policy and potential future policy, and also wider asset-based approaches. So exactly that, how do we put this into practice? What are we already doing well? What can we do more of? So from the perspective of wider NHS policy, I'm quite encouraged. So I've spent about 15 years working in the NHS, trying to help people improve quality and safety. And I'm quite encouraged by the language and what we see in policy generally. I think it's going in the right direction. There is a caveat on that there's still ways for it to go. But so, for example, in the patient safety strategy from 2019, and it'll be interesting to see how this is refreshed in the next strategy, there's explicit mention of safety too, and we can, whether or not that's helpful language, there's discussion about how can we think about safety from a resilience perspective. There's explicit mention of how do we learn from everyday work. And what's quite encouraging in that is there's discussion about involvement, thinking about how we get insight from a wider group of stakeholders. So Ruth was talking about resilient healthcare can be benefited when we broaden the system boundaries that we're looking at, and we think about how different things interact within our system. And the more we involve more people, very much patients and families and service users, but also different members of staff in our stakeholder groups, so that whenever we are trying to research something or trying to improve something, it gives us more appreciation for that wider system. And the safety strategy is looking at that and very much taking a systems approach, trying to understand more about how our systems are working. So that's really positive. And it also, the safety strategy links to the wider quality improvement agenda, much of which in healthcare is starting to take, Ruth talked about Taylorism and that idea of there is one way of doing something and we find the best way and we standardise to that. A lot of the work I did in improvement was underpinned by Deming's idea of the system of profound knowledge and actually understanding variation. And yeah, is it good, bad, is it good, is it bad, what do we need to do with it, who are the people working in it, how does that system work? And so that improvement culture is really positive. The Health Services and Safety Investigations Body, which was established in 2017, that looks, you might argue that it tends to focus on looking at where things have gone wrong and what we need to fix. They do, they take a systems approach. They are not there to apportion blame or liability, they're to understand the system. And they try to understand everyday work as done and really understand what people are doing. Although they might sort of take a spotlight on a particular bit of the system, they're trying to understand that in more detail. And there are people at HSIB who explicitly use very asset-based approaches to understand what people are doing in the healthcare system. So I'm going to talk about appreciative inquiry as one of those methods. And I know one of the investigators at HSIB uses appreciative inquiry as their method to understand how people are working in the system. And the Patient Safety Incident Response Framework, launched in 2022. This was something in particular that when this came out, I was really pleased to see the shift in how we're trying to move towards understanding safety from the perspective of really looking at incidents or a lens into our system. And we want to understand everyday work. We want to very much take a systems approach and using different methods that help us to do that. The complex map that Ruth showed you, all of the different interacting parts, there are tools like link analysis, which the PSERF recommends people to use, and a lot of you might be familiar with SEEPs as a way to understand systems, very much helping to shine a light, I think, on the complexity, which moves the discussion on to, and what do we do about that? Where is that? Where can we start to reduce the complexity to make it easier so it's more efficient, it's more effective, but still holding on to it, and how does that impact safety? Where is it important to enable variation, and how do we really understand the complexity of it and not try and simplify it down? I also particularly like PSERF and the way that training is spreading across the country to support PSERF. There's a lot of encouragement of wider stakeholder mapping. And again, that broadening the boundaries of what you're looking at to think about understanding all of the different elements of the system, which helps you to, it's that, for me, it's the first step. If we understand the complexity of all the interacting parts, it helps us to think about how we design better services and products and systems to help us move forward. That's not to say that designing those solutions is straightforward and simple, but it helps us to think about what we need to be putting into place. I think this is where I really like these bell curves to help us think about, as Ruth was saying, resilient healthcare isn't about ignoring that harm and error happens and things go wrong. It's recognizing that that is a part of all of our learning. And if we're only looking at incidents to understand the system, we are ignoring 95% of data. 95% is not a statistical, it's just an example. For anybody who deals with quantitative, I don't do quantitative, but we're only just looking at a little bit of what's happening in the system. Whereas if we are understanding everyday work, we've got a huge amount of insight that we can be getting and building on. And there are some specific things that are going on in the NHS already that are helping us to get some of that insight. So you might have heard of Learning from Excellence, which is a campaign started in the Midlands and is spreading nationally, which is about recognising where, not almost the flip side of where something's gone wrong, actually where has something been outstanding, and using that not just as something we're going to celebrate and give somebody an award because they've done something outstanding, but we're going to go and investigate, and we're going to go and really understand what enabled that excellent performance. What were the factors that led that team to be able to deliver such exceptional care? And positive deviance is a similar idea of identifying outliers and finding people who are people and teams who are performing, they're working in the same system as everybody else, but the results they're getting are outliers in a positive way, and going and understanding in detail what are they doing. Not just giving them an award and saying, well done, you're doing brilliantly, but actually understanding how all of the different things they're doing to adapt to the workarounds they've got, that actually if everyone else had that workaround and it became standardized, would really shift quality for everybody. And underpinning all of that, whether it's learning from excellence, looking at positive deviant cases, but also learning from error and harm, I believe it can apply to everything. There's a methodology called appreciative inquiry, which I am a huge advocate of. And I'm just going to give you a bit of insight into it as one way that we can think about how we are doing, looking at healthcare from the perspective of how do we build in resilience. So appreciative inquiry is it's a method, it's a mindset. It's once you're in it, you can't unsee it. I don't want to call it a cult when it feels a bit like a cult when you first start hearing about it. And it is a way of working that is very much focused on action, and it's focused on positive practice. Everything that appreciative inquiry does has a positive core. Even the name itself, we call it appreciative inquiry because it's about going and exploring and investigating and understanding, really looking in depth at something. And it's appreciative both because it is trying to find the looking in a positive way at things, but also if you think about if you put your money in a good place to invest, it appreciates, it grows in value. So we're not just highlighting the value, we are developing and growing the value in whatever we've got. And one of the tools that appreciative inquiry has is something called the 5D cycle, which is illustrated here on the slide. Was, as I say, all around a positive core. And it's very much about, even when we begin to look at something, we're going to choose an affirmative topic. So even if there's been an incident and what we want to go and understand this incident, we can frame how we are approaching it in a positive, affirmative way. Then we go and do some discovery, which might be ethnography, it might be interviews, it might be observations, all sorts of different things we can do to go but we focus on what's working well. We're not going in to look at what's going wrong and what are all the problems. There will definitely be positive things working in a system, even in systems that you think everything's going wrong, there will be positive things that we can value, and they're the things that we focus on in this approach. We take all of that understanding to think about all the strengths and the values people are bringing, and we co-construct a vision of a better future. So we get our stakeholders together, and we quite often do it through an exercise like we're going to imagine that we've already achieved it, and we're going to talk about what it looks like, but also how we got there. And imagining that you've already achieved it gives you a different mindset on the things that look like barriers. If we've got past those barriers, we know we can. So what was it we did to get there? We spend some time thinking about how we make that dream real, looking at our innovations, and then we put that into practice. Elements of this are very similar to a lot of improvement work that we do. Plan, do, study, act. There's not necessarily so much discovery in plan, do, study, act, but it's just everything we do is focused around having a really positive mindset to it. There's a whole load of principles that understand appreciative inquiry that I won't go into, but if you're interested in understanding it more, there's a really good book called Appreciating Health and Care, which is about the theory and the tools, and lots of case studies that give you examples of how it can be used in health and care. It's been used across a whole host of different industries, and health and care is adopting it as well now. So we thought we'd give you a bit of time to think about what this looks like for you and to have a bit of a practice with it. So the first step in our cycle is choosing an affirmative research topic. And we're aware that sometimes in research there's a problem and we're trying to fix a problem. And that means our focus is on the things that are wrong and broken and that need fixing. Even in research, we can come at it from what are the strengths we want to grow? What are the skills we want to develop? What is it that we want to add value with? And part of the principle of appreciative inquiry is being very specific and explicit about the words we use and the world we construct by the way we talk about what we're looking at. So what we're going to do, hopefully if the technology works, is we're going to put you into some small groups so that you can have a bit of discussion around this prompt. It might be that a few of you can share stories, one or two. It's not for everybody necessarily to have to talk, but we want you to think about a time that you or a colleague experienced an act of great care that has inspired your research and how it motivates you towards achieving your research aspirations. I'll give you an example to help you think about how it might not necessarily be specific to your current research questions, but it's what the motivation and the excellent care you've seen that is inspiring you. So the example I'll give is a personal one for me, which has motivated all my work in the NHS. It's not why I went into the NHS. I fell into a job in quality and safety, but once I got in it, I realised actually this is what drives me. And it was that I was 19, lying in a hospital bed and witnessing all sorts of things that were going wrong and wondering how on earth any of it functioned. Little did I know at that point at 19 that that was my human factors brain, recognising all of the design things that could be improved. But the thing that really stands with me and stays with me from 2 weeks in a hospital bed is one particular nurse who every day would use her time when she was doing other tasks around me, whether it was helping me stay clean, giving me some food, giving me some injections, observations, whatever it was. I don't really remember what the nursing tasks were, but I remember her because I wasn't allowed to move off my back. I was laying flat for 2 weeks and visiting time was limited. So I was on my own with very little for entertainment, and she would make time to talk to me and chat about all sorts of things, and not really anything to do with healthcare, you might say, but actually it was that compassion that stays with me, and it motivates me because I think everything I do to try and improve how our systems work in healthcare and to support teams working is to create time and space for those conversations. And that is my aspiration amongst all of the other work that we do. So I'm hoping that we can put you into a few groups. I have seen that Sobiet had joined us and hopefully can set us up some breakout rooms.
Yep. How many people would you like me to put in?
I would say, I haven't paid attention to how many participants we've got.
So I think we've lost a few on the turn of the hour, but yes, there's about 25 people in total, including yourself, Brooke. So
okay,
I reckon 4 groups of 6 or 7.
Yeah, and we'll give you maybe about 10 minutes for you to each, as I say, it's not there's no pressure to share if you don't want to share, but give yourselves time to think about these moments of really great care, hopefully more than moments, memories and experiences of really great care that are motivating you. And for those of you listening to others, we'd like you to pay attention to the language you hear and what draws your attention in those stories. We're not going to ask you to share the stories back in the main group, and we're not recording the breakout rooms, but if we've got time, we'll just invite some feedback on how it felt and to think about those experiences and those what motivates you.
Rooms are open.
Just so that. Okay, so I'm hoping everybody had a very lovely, slightly briefer than we planned, and in the interest of time, we're going to invite you to feedback in the chat. We're not going to have a discussion at this moment because we've got a few more things we want to share with you and make sure we've got time for discussion at the end. But it's just a bit of an insight into how something like appreciative inquiry can change our perspective, which is very much about how it's very much aligned with that thing about resilient healthcare as an alternative perspective and thinking about what we focus on. I've talked briefly about what's already happening in NHS policy and practice. There's a bit of thought about what could happen potentially in future as well. So there's quite a lot of discussion at the minute that I'm particularly interested in, because it's my focus of my PhD, about systematic management of safety in healthcare, and how we can be more systematic in what we do, and looking at how other industries have developed structured approaches, which we call safety management systems. And there's lots of places that this is getting discussed at the minute, and how we might think about it, which I think is really positive. But having a resilient healthcare perspective in it is really important, because if we look at models for safety management across a whole system, there are elements that can really support resilience. So they often talk about worker involvement, and I would expand that in healthcare to patient and family involvement. The people who are working operationally understand the system, and they are best placed to help us think about the risks within it and how we manage them. These models have continuous improvement built in. So resilient healthcare is about monitoring and responding, and continuous improvement is really important for that. And monitoring operational performance. So again, really helping us to think about what is happening day to day that we can make sure we're looking at. And healthcare already has some of the thinking around plan, do, study, act. And the model on this slide is from the rail industry, and there's elements of it that we have really, we have got in healthcare that we can build together. There's also an opportunity for healthcare to think about how we build resilience in. So in other industries, they have traditionally been a bit more focused on learning from the things that have gone wrong and taking those errors and harms out. And I think there is a lot that healthcare can do with that. But they are also, in these other industries, starting to think about how do we think about the fact we've got complex adaptive systems, and we can't necessarily plan for every eventuality. So we need to develop a system that enables us to be adaptive. And there's some examples in other industries of how they're doing that. But there's an opportunity for healthcare to really lead the way as well in thinking about that. There's some tools already out there that can help us. I haven't seen them being particularly well used in practice in the NHS, but things like Vincent et al.'s measurement and monitoring framework. I think this speaks to the question of how do we operationalise it? What data do we have that are we collecting, are we paying attention to, that tells us not just about past harms and things that have gone wrong, but how reliable our services are, how much we are sensitive to what is happening day to day. Can we really tell what day to day looks like? Are we anticipating things and getting prepared to be able to respond in different ways? Do we have data on how we're integrating all of that together and learning? We have pockets of all of these bits of data, but are we bringing them together in an effective way? And also thinking about, again, Vincent and Amalberti's work about thinking about where we operationalise resilient healthcare. We need to be conscious that healthcare is not all the same across all different sectors. And there was discussion earlier about this in terms of hospital at home and paramedic services. A&E is very different to, for example, radiotherapy, where it's more possible to standardise and look at our risks in different ways. So resilient healthcare as a mindset needs to be, we need to think about the sort of environment we're working in. And again, that's about broadening our boundaries to think about this particular healthcare we're looking at. What system is it sitting in, and talking to the different people there to think about how we approach it in different ways and the strategies we take. So there's lots of different elements of existing insight that we can help to build how we look at our resilient healthcare.